Welcome to tonight's webinar, Hepatitis C in General Practice. We are joined tonight by speakers Dr. Scott Davison and Dr. Nada Endrick. My name is Serena, your RCGP representative for this evening. Before we get started, I would like to make an acknowledgement of country. We recognize the traditional custodian of the land and sea on which we live and work, and we pay our respects to elders, past, present, and emerging. I would also like to acknowledge any Aboriginal and Torres Strait Islander colleagues that have joined us online this evening. To introduce to our presenter for this evening, Dr. Davison is a staff specialist at the Liverpool Hospital and a conjoint lecturer at the NSW. Dr. Davison is dedicated to provision on high quality medical care to a broad population of the community with a focus on liver health, cancer prevention and management, and viral hepatitis. He has extensive clinical experience in chronic viral hepatitis B and C and contributes to clinical research in the management of these conditions. He has been an educator and speaker in various capacities in relation to these topics, with a particular interest in chronic viral hepatitis in Indigenous Australians. Dr. Endrick is a general practitioner at Earlwood General Practice in Sydney and a head of vocational education at GP Synergy. Apart from medical education, her special interests are in the health of marginalizing population and viral hepatitis management. She's also interested in providing holistic care of people with severe and enduring mental illness. Her research interests are in primary care provisional of hepatitis C treatments. I'll now hand it to Nada.
Oh, thank you. Now, I might see if I can share my screen. See if that works. Tell me if it does.
Yep, perfect.
Oh, excellent. Alrighty. So I might just go through, thanks so much for the introduction, and thanks everyone for joining us this evening. I might just go through our learning objectives for the evening. The first being to increase GP confidence in identifying patients for testing, including how to initiate a testing discussion, understanding hepatitis C testing options and how to interpret results, learning about hep C treatment options and how we can prescribe treatment, and also understanding which patients need referral to specialist care and how we get them to see our specialist colleagues. So we'll just start up by a quick introduction. Most of you already know a bit about chronic hepatitis C. So hepatitis C is a blood-borne RNA virus, and it affects the liver, and it is curable, certainly more curable since the introduction of the DAA therapies in 2016. So 58 million people globally have chronic hep C, so it is quite a common illness, and the transmission mode is blood-to-blood contact. People with hep C often don't have symptoms, but when you do treat hep C, people who have had hep C and no longer have hep C feel lots better. They may be less fatigued and they may feel more, I guess, engaged with the world. Less brain fog is what a lot of people say. So even though there are no specific symptoms with hep C, people do feel better when they don't have it. Highly effective, well-tolerated oral therapies have been available since 2016 on the PBS. And that's been a huge change in how we have approached chronic hepatitis C treatment and care. And in fact, I think, you know, now it's not even as big a deal in Australia as it used to be. We've done such a fantastic job in treating so many people with this illness. Untreated hepatitis C can cause liver disease, cancer, fibrosis and cirrhosis, much like any of the other illnesses that do affect the liver. And the New South Wales and Australian Hepatitis C Strategy is on, I guess, on track to eliminate hep C as a public health threat by 2030. And I think this education that we're doing tonight is sort of part of ensuring that we can engage as many people into testing and to treatment as we can. So, Scott, I think you're next on board, if that's all right, just to identify people for testing.
Yeah, I just want to sort of flow into this by saying that identifying is probably the biggest challenge that we have in hepatitis C now. the drugs work wonderfully well, and they're really easy in almost 99% of cases. But looking across the desk from you and thinking, could this patient be someone who will benefit from a discussion about hepatitis C, and how do I get this in train? This is really the big challenge. I'm not typically in front of patients that I'm going to describe now in the first instance, and you are, and that's why general practice is really the forum for us to have these discussions. We're looking at a group that may be easily identified according to their previous injecting drug use or exposure to blood-borne viral infections. Now, that might be people who self-identify as injectors, people who've been incarcerated previously, but also if you were born in Egypt in the 50s and 60s, the program of schistosomiasis vaccination involved needles going out of one arm and into another. And as a consequence, 15% of Egyptians, I think it might even be more, will have the particular viral strain, the genotype that is endemic to that area. And that's all part of that program of vaccination. So there are patterns of epidemiology throughout the world that are based around iatrogenic exposure to the virus as well. In the Indigenous population in Australia, we know that there are higher rates, and that probably relates to some of the cultural practices or perhaps some of the ways that health is managed in those communities. But predominantly where I'd like to put emphasis tonight is that we are under-testing patients who might be going to Bali for a tattoo, or to other Asian countries where the Vaseline pot is a great transmission spot for blood before the needle goes into the skin, and that can be a spot for transmission of the virus. Needle sting injuries at the occupational place of work, co-infection with other viral infections. Patients where you're not really sure why, they've got liver inflammation or cirrhosis, mothers born to hepatitis C positive, mothers with babies, healthcare workers, and people engaged in sex work may be at higher risk of that as well. And that, I'm not sure if we're going to talk about gay men and HIV, but that's another sort of forum for infection as well. So we might move on there. Broader screening outside of just is this person an injector is really warranted now. We're going to have difficulty reaching the elimination by 2030 unless we look at a broader group to make sure that we're covering all of the population with testing. Now, if you don't identify these infections, there's a whole host of things that sort of swing into effect, and we think about 20 years is what is the lifespan of well, it's from the start of the infection to the time when the consequences are really felt. So an acute hepatitis C infection goes into a phase where a lot of people actually develop a chronic infection. Only really 20% will spontaneously clear the virus. They'll be left with a marker, the hepatitis C antibody that identifies them as someone who's had the infection previously. So majority, 80%, will develop chronic hepatitis C. At about 20 years, 10% of those patients will be developing cirrhosis, and a lot of them will have chronic inflammation or elevated ALT and AST as their markers that go on for many years. Of those cirrhotic patients, 4 to 5% will develop a decompensation event. That might be a varicose hemorrhage or peripheral edema or jaundice. Quite a substantial portion will develop a cancer, so that's about 3%. So it's a very preventable cancer if we can address the root cause, that's the infection. And unfortunately, death from hepatitis C is still going on, even though we've done quite a fabulous job in the last 10 years of identifying and treating a lot of patients. We'll just move on there. Looking at the way that this 20-year flow goes, you go from a healthy liver that looks, red and sort of has a predictable small size to being something that's enlarged and full of fat. That's one of the hallmarks of the hepatitis C infection in many instances is a fatty liver. It can start to develop some fibrosis before it develops a nodular contour. That's the cirrhosis that 20 to 30% of patients are experiencing at 20 to 30 years. And then liver cancer, or sort of, solid lesions that appear out of the cirrhotic liver, or in many instances, they develop at a rate of 1 to 3% of the year in these patients. Now, this is getting into the specialist territory. This is not very common. And in the early part of my career, when hepatitis C wasn't treated in exactly the same way, we did struggle with a few patients here, but lymphomas, glomerulonephritis, and other autoimmune conditions, including vasculitides, they do flow out of this infection. One of the ones that was really, I used to think was really fascinating was cryoglobulinemia. Used to get women, or like elderly women with very sort of awful looking legs from this terrible vasculitis that was easily cured by treating the hepatitis C. But by that stage, a lot of people were up for the treatment of the day, which was interferon. Thank goodness we don't do that anymore. It was a terrible treatment, but it's very much in the rear vision mirror now. Diabetes mellitus can occur as well, and there are some other unusual dermatological conditions that I've not really had much to do with in my career. I think Nada's going to kick on with.
I think I will. I mean, I guess your points are really valid, Scott. I think, we have done a very good job at treating some of the people who are kind of already engaged in care, and who have had testing and who are quite engaged in their communities and engaged in their health. But there are definitely people across Australia that have been told, 20 years ago that it's Hep C, don't worry, you'll never get rid of it. And those people are still living in the community and potentially still at risk of fibrosis, cirrhosis, and hepatocellular carcinoma for something which is now like actually curable. So they're the clients that I think that we're trying to target for testing. When we think of testing, it is fairly straightforward. Testing sequence is really testing someone who may be in a priority population, or someone who's just come in and asked for a bloodborne virus screen, starting with a hepatitis C antibody. So I guess basically we screen people, like we might even screen, for bloodborne viruses in general, Hep C, HIV, Hep B antibodies. We might add a syphilis. If we're just doing a general sort of BBV STI screen, that might be part of our entire screening profile. And I know a lot of AMSs have already incorporated hepatitis C into their care plans and into their sort of normal structure of care and their standard of care for their clients. But we start with a hepatitis C antibody test. And if we have a positive antibody, then we go on to a hepatitis C RNA test. If we have a negative hepatitis C antibody test, we stop testing at that time because we know that someone hasn't been exposed, that our patient hasn't been exposed to hepatitis C, and it's a non-reactive test. If they have been exposed to hepatitis C, what we want with a hepatitis C RNA test is to figure out, do they still have hepatitis C, or have they been treated and just have a positive antibody, or have they cleared the virus, like the 20 or so % that Scott went through earlier. So what we want to figure out is, does this person currently have hepatitis C infection? And the only way to do that is to test for the hepatitis C RNA in someone who has a positive antibody test. So if we have a positive test result for a hepatitis C RNA, we know that that person does have hepatitis C and they have a current infection. And that's our chance to sort of have that discussion with that patient around, talking about engaging them into care, talking about treatment, and the fact that it can happen very quickly with over-the-counter medications that are quite easily accessible and quite well tolerated. What we do often get wrong in general practice is the understanding of the hepatitis C antibody test. I think a lot of people can stop and at the antibody and think, oh, we've got a positive antibody, that person's got hepatitis C. But we really do need to proceed to the RNA test to ensure that the blood actually has the RNA in it. And that way we can tell the patient, yes, we definitely have tested for hepatitis C and you do have the virus. It does need a second dedicated tube. I've been caught short before with only taking sort of one of the serum tubes. So it is useful if you're taking blood in clinic to take two of the yellow tops and you know an INR as well as one of the purple tops if that's what you're doing, just to make sure that you have enough blood when testing because some of our clients definitely have veins that are a little bit more difficult than normal. And you don't particularly want to rescreen. So that's where we, on the form, would write hepatitis C antibody test. If positive, please proceed to RNA testing. It does say here that some private labs already do that, and they do, but it's a little bit hit and miss. So I would continue to write, you know, the if positive reflex testing request on all of my pathology forms anyway. Okay. Oh, gone a bit too far. So there is some really good information out there. ASHM has some fantastic information. The decision-making tool for hepatitis C is just an easy two-pager, and it will go through who the client group we're looking at for testing and very simple sort of decision-making and what we need to do from that point onward. For a little bit more in-depth information, the consensus statement in chronic hepatitis C is available, and that's a GISA, Gastroenterological Society of Australia document. And there's been a little bit of movement in, you know, when to test for cure and so forth. So it is a really good statement to read every so often if you're interested. But most of the information that you need in general practice is really available on that decision-making tool from ASHM. I think we've got the link going out with this slide deck, but if you just Google decision-making tool in hepatitis C, it will come up and you'll be able to see it. And all the links in the tool are also live links. So I might just continue on if that's all right. We've got other ways of picking up hepatitis C that are available, not just your stock standard blood draw in general practice or from a pathology test. We definitely have clients that don't have easy venous access. And that's actually incredibly stigmatizing. And I think that's why we haven't been super successful in treating chronic hepatitis C in this country. It's not like your stock standard urinary tract infection where you can go into the GP and just say, look, I've got urinary frequency and get the treatment. You know, there's a whole bunch of stigma that comes with having this infection. And I think getting treatment and seeking healthcare, and that's mostly because of its transmission, the risk factors associated with transmission, and people that sort of have previously injected drugs or people that have acquired the infection many years ago may still carry that stigma and may not even want to speak to you about their hepatitis C status. So that's something that I think that we need to be aware of, but also that's why so many of these other ways of detecting hep C are so important. So point of care test is something that they do use quite a lot of now, particularly in people who are in prison, and sort of being able to reliably take just a finger prick sample of someone's blood and have a positive PCR result at the end of that is pretty amazing, particularly because in the past we used to wait for, you know, a couple of weeks sometimes to get a genotype and a viral load from some of our blood draws. So now having something that's available in less than 60 minutes and then being able to actually prescribe treatment at the time is pretty incredible. This is sort of through a national point of care screening program that has been funded by the federal government and is available through sites across Australia, pretty much run by local health districts and people associated with local health district testing teams. It may not be as readily available to our regional colleagues, but if it is available and if it's coming your way, I think it's really something to look out for. In New South Wales, we're really lucky. We have access to the DBS tests, so we can refer our clients who may not be super keen to engage at the moment to having a sort of a DBS test, a dry blood spot test that can be sent out to them, to their PO box or to their home after answering a few questions online that look at risk factors. So DBS is available for both HIV as well as for hepatitis C, and a PCR test is also done on the dried blood spot samples. So if you are in New South Wales and you do have some clients that might have incredibly difficult veins, don't really want to engage at the moment, but might be interested in getting the test in the future, I think referring them to the DBS test is really fabulous. Have you had much to do with that, Scott?
Sorry, I turned my audio off. No, dried blood clot had a sort of a vogue in public hospitals where I work some years ago, and it does get used in our injecting sort of site. But in hospital, we have such great facilities for pathology collection that we just use that as our mode. It's very effective though. The only weakness in the model that concerns people like myself is that linkage to care is still something that is important. And I guess as an extension out in a practice like mine, we do B and HIV concurrently, and this is just one little slice of the bloodborne viral thing. And I'm not sort of diminishing that in any way, but it's a start, and it's a fabulous start if needed.
Excellent. Thanks. All right. So we'll click on to the next slide. And that sort of is just on pre-treatment assessment. So just moving on, after we do our initial sort of discussion with the client around risk factors, or even, figuring out whether or not the patient's interested in getting testing, or if they're worried about anything, or if you as a GP is worried about, an increased liver function test or something, just a general bloodborne virus screen, we do need to do a comprehensive assessment before we embark on treatment if somebody does have the positive PCR test. So in times past, very early in the piece when the DAAs were available, we did need a quantitative RNA result as well as a genotype to assist us in managing people with hepatitis C, because different medications were available for the different genotypes. But now we're really lucky, and both of the main medications we use for hepatitis C work on all genotypes equally, and they're equally efficacious and they're very effective. So I haven't asked for a genotype in a very long time. And in fact, I think that would also take quite a long time to come back from the lab. In our pre-treatment assessment, we also do ask about previous treatment, and I think delineating between previous treatment with interferon versus previous treatment with our current DAAs is important. I think we need to figure out if someone's had a discrete infection that has been diagnosed, cured, and they have a new infection, or whether or not somebody might be, not have a completely treated illness or infection, and that's where we might need to refer them to the specialists in that instance. So figuring out if someone's been treated previously and if they've been given a cure, a result, an SVR result, is important. I think it's also important to figure out how good people are with their tablets, if it's a good time in their life to take tablets every day for a couple of months, or if it's something that they need to hold off for a couple of weeks or, a little while until things are a little bit easier. Obviously, having the patient in front of you makes it a little bit easier to really engage with them and try and put into place some strategies for adherence. Obviously, with OTP, people can pick up the same time they might pick up their methadone or Subutex, or, they might be able to pick up weekly if they're on weekly Buvidal. But really trying to make a plan in case non-adherence becomes a problem is important. Because hepatitis affects the liver, it is important to talk about alcohol intake, and sometimes very heavy alcohol intake can really influence how good people are with taking their medications as well. So not only does the liver get impaired with heavy alcohol intake, which is sort of like a double whammy, I guess, but also some people who are really quite heavy into the alcohol may not be as reliable with taking their medication. So it is important to ask. It's important to know which medicines someone's on, just because there may be some drug interactions, and Scott will talk about that a little bit later. Treatment in pregnancy is not something that's indicated at the moment. I think it's being studied, and I don't think it's hugely bad, but it certainly isn't a category, like a safe category of medications at this stage, the DAAs. So we often hold off until after breastfeeding has been completed until we can actually treat women who are currently pregnant. Pregnancy is a fantastic time to pick up Hep B, Hep C, and really have women engaged in care. So I think it's a really good opportunity to have those discussions and really keep people engaged until they're so ready to embark on treatment. Weight and BMI are important. Obviously, there are lots of things that may continue to impair the liver function even after treatment. So what we do like to have is a bit of a baseline weight and BMI for those clients. And obviously, a quick physical examination, signs of chronic liver disease is important, and your stock standard blood tests, so FBE, EUC, LFTs, and INR. A cirrhosis assessment is probably the most important thing. And I think when you do call up for the authority prescription, you are asked by the person on the authorities line if the patient is cirrhotic, and you should be able to answer that question. So we will talk about cirrhosis assessment next, and that's either through an APRI score or a fibroscan. The APRI score is the most accessible, and the beauty of the APRI score is it doesn't really matter where you live, you can use it. So if you can order an AST on a client and you can order a platelet count on a client, then you can do an APRI score, and that gives you a pretty gross marker of fibrosis. And certainly the AST to platelet ratio is something that we continue to use to assist us in figuring out if the person is at risk of cirrhosis or severe fibrosis. We can use the calculator, and we'll use the calculator in a little bit of time as well, just as we're going through the assessment. So a low APRI is a good thing. Any APRI over 1 is something that we assume someone may have high risk of cirrhosis with. The other, I guess, tool we often do use for a fibrosis assessment is a fibroscan. And a fibroscan is an elastography investigation. There used to be a fantastic slide about this that talked about assessing the thickness and fibrosis of a liver. And it was based on a machine that used to test for how thick and how cirrhotic how thick brie cheese was. So the machine is actually based on an aging of cheddar cheese kind of machine, or brie cheese machine. But it is really, like I like to explain to my patients, we're really lucky we've got one. I like to explain to my patients that it's trying to figure out if your liver is still a bit like jelly, or if your liver is a little bit harder or more like a brick. And really what we want is a nice jelly-like liver. So I don't know if you have anything you want to talk about with respect to the fibroscan, Scott?
I could talk about fibroscans for quite a while, but essentially, your analogies are really important. That sound will travel differently through these organs of different density. If you've got a lot of human between where the probe sits and where the liver is, the reliability of this type of scan may be altered. So it's if people have really, really kind of big wastes, that could make it a little harder to use. But essentially, when it comes to my assessment of cirrhosis, I will use this and other bits of information, including abdominal imaging and what the liver looks like, to put together an opinion. It's rare that we biopsy, is kind of where I'm going with that.
Yeah, I guess what would you do if you were in sort of like a regional or rural area and really didn't have this sort of access? What sort of other tools might you use to figure out if someone's at risk of cirrhosis?
I'd certainly be looking at things like platelet count and other aspects of the way that the liver functions, the hepatic synthetic markers of INR, bilirubin, and albumin. But probably the thing that I would find most reliable is to get a service that you respect to do an ultrasound and try to look for features of a nodular contour of the liver. Now, if everything looks normal and if all of the markers that you're collecting in your serum are normal and the organ looks normal and there's no signs of portal hypertension, it's very unlikely that cirrhosis is present. So that's a bit rough and ready, but that's a way to go around this, really quick and easy tool to come up with an assessment that's pretty reliable as well. You're on mute.
I think Serena's going to share from now on. Thanks so much, Scott.
I think we're up to my bit about treatment now, and the direct-acting antivirals were a revolution that occurred, in the middle of the last decade that has really changed my practice at work. You can move forward there, Serena. They're all oral and quite easy to take. They really don't have side effects that I would care to prioritize as a factor here. They either last for 8 or 12 weeks, and between 93 and 99% of patients are achieving what's called sustained virological response by using these medications. It's pretty rare that we come across infections that aren't treated. Next one, yeah. The SVR is now considered to be a cure, and there are thousands of Australians who live in sustained virological response, and the rate of recurrence of these infections, I'm not sure I've ever seen one. We don't suggest that anybody, even if they have just been infected, waits for clearance. So we always just get started. All of the two therapies we use now, Epclusa and Mavorite, they're pangenotypic. They're supplied through authority prescription, S85, and any GP is able to just get going on these scripts. I'm not actually sure where we're up to with the referral to some sort of external body, but I think that those days are over. Is that right, Nada? No, you don't know?
I was going to ask you about that because I think, some of our very sort of straightforward patients might actually, just this education and us speaking about some of these cases is probably enough for us to be able to prescribe this with some confidence. But I think some of our more complicated patients may still need to go through the process of a remote request form. So that will really depend,
I'm not sure if the remote request form is in this presentation, but it's essentially just a bit of data that goes through what that initial data collection table that Nada has already spoken to, and it allows you to sort of prioritize within the information that's been made available to you during your time with your client, to make sure that it's a safe thing to do, it's the right therapy to apply for this particular patient, and that there's no issues that are going to get in the way of it. And I wanted to emphasize something within what Nada said. I actually personally believe that the most important part of the therapy is, will the tablet leave the box and get in the mouth? And by that, I mean, is your patient distracted by something else that's going on in their life? And are they going to not take these tablets over 8 or 12 weeks? So people who are homeless, people who are currently going through some other substance use issue, or who have other big things going on in their life, it's probably just not the right time to start. And that's the issue to really focus on there. And you're all sensible enough to see your patients going through big deals that might be the priority rather than hepatitis C, I think. Minor side effects, nausea, headache, fatigue. I don't know. I haven't actually met many patients who've reported those, but most of the time it's my nurses who do the treatment. So I'm sort of a bit removed from the side effects side of things. We'll move on there. Oh, sorry, just that. So can you just go back, Serena? I should have said that the 6 genotypes that we've got, 1 to 6, they are treated by both. There is a slight difference. If you've got cirrhosis and you're on Mavorite, you don't get a short course, the 8-week course, you get a 12-week course. And the only other difference with those two therapies is that Epclusa or sofosbuvir valproatovir, it's a 1 tablet a day versus Mavorite. I'm not going to go through those names because I always muck it up. Mavorite is 3 pills a day. Okay. Anyway. What's really important to deliver back to a specialist? If you see someone who's got cirrhosis, it's not so much even that the infection is difficult to treat. It's more that after a patient is cured or goes through an SVR and they're at the other side, what happens to your patient then? Now, a lot of sort of probably there's a type of patient who'll take it as a green light for alcohol use or everything else that they wanted to do with their liver. They're going to get going on it right now. And those patients are on a steady path to cirrhosis from a different etiology, and they may already have preloaded themselves with quite a severe liver injury from hepatitis C. So we don't want to do that. If someone's got obvious skin manifestations, they've got renal disease, or some other condition that you can't tease out as being clearly not related to their viral infection, then yeah, obviously send on to me. If there's someone who's, the really complex patients I've had to deal with have actually been cardiac patients on amiodarone, because those therapies are really difficult to discontinue. And some of these therapies I'm going to describe how we can't really mix these drugs together. And for that reason, you need to really work with a cardiologist to get the program for heart care going in the right direction. Kidney impairment, I've already spoken about. If you've got somebody who's HIV or Hep B co-infected, the therapy still actually runs pretty similar to a standard therapy, but there is definitely some nuance to it that would benefit from the specialist to be involved. If somebody's already failed a DAA, it's not the end of the world. We can definitely retreat using another therapy. There's actually a therapy like a line of therapy called Vasevi, which is a triple. So it's got 3 antiviral agents in it. I'm not going to describe that here, but that's up our sleeve if we need it. Somebody with acute hepatitis C, rarely, really, really rarely, these people end up on ventilators for severe liver failure. So you don't really want to muck around with somebody who's circling the drain with hepatitis C in its acute phase. And juniors, I don't actually look after peds myself, but I've certainly been involved in their care before, and they would be better off in a specialist practice for sure. So we've already spoken a little bit about forms that are used in remote request, and point 2, the GISA remote consultation request form is an online site that allows you to move step by step through the collection of information. The REACH-C, which is, I think, a very similar, I'm actually not really familiar with that form right now because it's been a while since I had a look at this presentation, but REACH-C through ASHM would be very similar and would help you to make your own decisions and also move towards specialist referral if needs be. They're available on those websites there, through addresses. Next one there. Okay, you've got your patient, you've decided to treat, and you want to know about what do you do on treatment. Monitoring on treatment is not thought to be something that is essential. If you've got a patient who's unwell with nausea or headache, they will probably turn up and want to talk about it. We wouldn't ordinarily change that therapy if the adverse effects are mild, but you can definitely take them off if you're worried and send them to a specialist. Interruptions are discouraged very sort of strongly, but there's this sort of weird data that comes out, particularly in injecting drug users, where they looked at the length of time that it took to complete the 8-week or the 12-week program, and the length of time that it took didn't actually really correlate so much with the outcome, the SVR. So these therapies are quite sort of durable, even if tablets don't go in at the right time. You certainly are encouraging patients to not interrupt if possible. As you finish therapy, there is really good data to say that if you do a qual, I've already sort of put this in the chat, but rather than count the RNA viral particles, just the presence of the virus in the serum at 4 weeks or 12 weeks is a reliable indicator of sustained virological response. And if you're only able to get a 4-week post-treatment blood test, then that's pretty good. But our standard of care is for a 12-week test. So you can see there that the ASHM guide has got the box for monitoring and follow-up. I'm going to talk about follow-up now a little bit. I would do LFTs at the end of therapy as well. I think that's really important. You may find that your patient gets rid of one component of their liver injury and you see that you've sliced some of their ALT and AST elevation off, but they've remained in liver inflammation, and there's a reason that there's something else going on. And that's really where I earn my money through state health. I spend a lot of time with trying to work out what's going down with this sort of patient. Next one then. Okay, we're going to go on to a case study now and pull it all together.
So we'll start with Mark. Mark is a 42-year-old unemployed male who's new to your practice. He's just been released from custody. In his background history, he's been injecting methamphetamine since 2005, and he's still injecting only occasionally. He rarely drinks alcohol, has a past medical history of reflux, which he's on esomeprazole for. He has a thin body type with a BMI of 20, no stigmata of liver disease, and does not identify as Aboriginal or Torres Strait Islander. Would you offer Mark a hepatitis C test? And next slide. I guess we would. Yeah, nice thumbs up. That's right. And so I guess when we look at this scenario, we look through the hepatitis C ASHM tool, and the decision-making tool will assist us in ordering the right tests. We'll order the FBE, EUC, LFTs, hepatitis C antibody HIV test, hepatitis A and B testing, as well as an INR. And we get a result that Mark has a positive hepatitis C antibody. And so we do a reflex test, and that shows that he has active hepatitis C. And he is suitable for treatment just by having that active hepatitis C result. Is that correct? If you've got a positive PCR, Scott, is there any kind of time frame? There used to be a 6-month time frame to say somebody was chronic. I'm just wondering if there is a time frame now for when you treat.
You know, Nada, I don't see very many acute hep Cs, maybe one a year, and I don't really think about this. I just give them treatment. So
Okay.
if I meet somebody who's got, you know, an exposure and an acute infection, I would just get them started on treatment right away rather than think about where they're up to in the infection. Yeah.
Excellent. And I think that's very reasonable, because how often are you going to get someone back in 6 months' time exactly to check for whether or not they still have the virus? So interestingly, for this particular scenario, Mark has had a genotype test done, and he's genotype 3A. Would you say that's a common genotype?
3, in Australia, it wasn't the most common. 1 was the most common, but 3 is pretty, you know, it was up there. Yeah, I mean, 1 and 3 was sort of around about. Yeah.
Awesome. But yeah, often we wouldn't actually get this result at all unless we specifically ask for it. Next slide, please. So we're going to do a pre-treatment assessment for Mark, and you can see that his AST level was 45. And his platelet count was 419. So we're trying to calculate an APRI score with the AST of 45, normal, upper limit of normal for the AST is 40, and then his platelet count is 419. And so his APRI score is well less than 1. So that's kind of in the range that sort of suggests that he's not overtly fibrotic or at risk of cirrhosis. But you could see that if the platelet count was really low, so say if it was only like 80, you could see that that APRI score would really push above 1, and so we would be more concerned about cirrhosis, and then we would probably make a decision about what to do next. So if the APRI score is above 1, we do want to do some further testing. So we want to either do some more imaging, so ultrasound, fibroscan, elastography, whatever we've got available.
Yeah, I wouldn't recommend that this patient be referred for any further testing on the basis of what I see right now.
Perfect.
Sorry, I'm not sure if I'm answering.
No, I think that's great. And the next slide, please. Somehow we've managed to get marker fibroscan, which is wonderful.
Yeah.
And these are the results. And I guess the good news is that I do know what the liver stiffness, actually, I know what both of them are, but I guess could you explain how
Yes.
important it is having a CAP as well as a fibrosis assessment for Mark?
Yeah. So I do fibroscan clinics where I get members, patients referred in for opinions based upon their fibroscan, and I find the use of both of these measures extremely helpful. So there are times I just want to draw attention to the colours on the fibrosis arrow there. You see a green F0 to F1 where our patient Mark is sitting, and that's a very reassuring result. It's really quite solid that cirrhosis is excluded when you get a number like 6.2. And you may even see his fibroscan result go down after treatment, which is again really reassuring. And I also just sort of point out, I mean, I do quite a lot of this and see patients walking in off the street with fibroscans of 15 or 20, and I can be certain that cirrhosis is their diagnosis. So, that's really helpful. In the middle there, when you've got somebody with 7 to 12 zone, it's quite difficult to be really quite settled on the fibrosis level. And in particular, you may in fact have somebody with cirrhosis who has a fibroscan that's less than 12. One of the parameters that I use to think about this, though, is steatosis, or the CAP, which is another way that sound is used going through liver tissue. It's sort of like if you can imagine a pool of lipid speeding up the flow of sound, and then it suddenly stops again. What you've got is this sort of staccato signal coming back at the probe. It's measuring something that's interrupted. So you get this. The CAP is quite a reliable measure of steatosis, and in chronic hepatitis C, you can see there's a band between above 250 where the fat content of the liver is significant. Now, fat just by itself is able to promote the stiffness of the liver. So there are times when I meet somebody who's got a fibroscan of 10 and a CAP of 350, and I think, I think you've got a fatty liver, and it's really hard to tell what's going on with the stiffness there. Suffice to say, I'm able to give quite a good opinion there to say, I think that whatever you came in with, you've got your hepatitis B or your hepatitis C. I think that steatosis is a cofactor, and it may in fact be the dominant factor. So we're going to work on both of these things, and that's sort of how I might shape an opinion out of the information from liver stiffness and steatosis. What's important here is that the dynamic process of doing more than one fibroscan is able to tell me whether treatments have happened successfully or whether we're on the right track of rehabilitating the liver. Sorry, long answer there.
No, I guess the next question, and maybe this is a teeny tiny question, is what do you do when you have a CAP of 350 and you know you've got a patient who's got significant steatosis? Do you want to see that patient, or are we meant to do something about it in general practice?
I'm kind of a bit of an extraordinary gastro. I'm just a hepatologist, and within hepatology, I've developed a really big focus on making sure that people are aware of their metabolic health and that we are doing something about it. And I have clinical trials for drugs that are going to revolutionize the face of hepatic steatosis. And let's move on.
Okay, sorry, yes, let's do that.
I'm really into your patients if you've got them.
Okay. All right, next slide, please. So just going back to Mark, we know that he's got chronic hepatitis C. We think that the date of infection was 2005, but we're not exactly sure because he has been injecting intermittently, injecting drugs intermittently since that time. We have a genotype of 3A, and we do have a very, like a 2.3 million copy viral load. We know that he has no fibrosis, no comorbidities, normal renal function, just is on some esomeprazole really. And we know that he hasn't been on any medication before. Treatment before. What do we do next? And I guess it's treat. Can we go to the next slide, please? Can he be treated in a primary care setting? And is ongoing injecting drug use going to be a barrier to his treatment? So yes, exactly. He can be treated in a primary care setting, but will ongoing injecting drug use be a barrier? And that's right, Stephen. No, it won't. So the beautiful thing about these medications is that they should be offered to everybody, no matter what their sort of risk factors of ongoing injecting drug use are. You know, really having people engaged in care and minimising their risk of ongoing liver harm, but also the harm of other people is really important.
Yeah.
Next slide, please.
You can keep going there, Serena.
Oh, yep, great. And we do have, oh, if you just go back one click, if that's all right, there is a fabulous NSP outlet map available. If you do want to know where your local needle and syringe program outlet is or vending machine is, you can just Google NSP outlets, New South Wales Health, and you'll come up with that particular map. Sorry, next slide now. Thank you. Scott, this one's for you, I think.
Yeah. I've sort of talked to this a little bit. Eclusa and Mavorite are both the right treatments to be thinking through. They're quite similar. Some patients would hate the idea of putting 3 tablets in their mouth and would be kind of, I just want one. And some people would say, I don't want to go for 12 weeks. I want to go for 8 weeks. And if you've got a simple patient like Mark, you can give them either. It's the outcome of the treatment is equivalent. And I can say that with great confidence. If you want help, if you'd like someone to support you in your decision making or just whatever bit of the care, there's really good services available through ASHM or through GISA, and we are, this is our bread and butter. We're right into answering questions with general practitioners who may be of varying levels of exposure to hepatitis C treatment or even the patient cohort involved in hepatitis C. And that we've got good connections. If you were wanting to get somebody into a sort of a specific drug and alcohol harm minimization type of frame, we've got quite good connections there as well. Drug-drug interactions. Now, there's this amazing website that's run through the University of Liverpool, not Liverpool Hospital, where I'm from. Liverpool University in UK have the ability to throw one of these 2 drugs or both of them alongside esomeprazole, and you see that there is a weak potential interaction with esomeprazole and a sort of a stronger one, the potential interaction for Epclusa, that you'd think, oh my gosh, I can't use this. And actually, if you dig down a bit, there's quite a text alongside there to say that if you give these therapies, you may decrease the effective antiviral therapy in some instances, and this is overcome by just not co-administering them within 3 or 4 hours. So these sorts of interactions are typically able to be overcome. And if you were at all wanting advice, or if something looked more complex than you could dig out from the hep drug interactions on org.org website, if you really wanted some help, going through the specialist program would be fine. If you've got somebody who's on a real shopping list of drugs and it's really hard to work it all through, that's probably somebody that I wouldn't waste your time there, because it can be very tricky. And I don't do them myself. I give them to my pharmacist, and that's very nice because they get to spend a bit of time doing all this technical work that's fun for them. Okay. If there are drug-drug interactions, what are other options? So if you really wanted to, exclude the chance of the interaction, the H2 receptor antagonists, I use nizatidine, but famotidine, that's something that could be used with epiclusa. And you could put them onto Mavorite, which has this lower chance of interaction, and that's really how we do measure it. Sometimes I give advice to patients that your therapy, your beta blocker may change its effect, and you might get you might need to stand up more slowly, and that's because there's a potential interaction, and the interaction has been talked about before, but it's not a very a well-established interaction. And in particular, the nursing team that I work with are great at giving really clear advice about that. Post-treatment and monitoring. So Mark's gets treated with Mavorite, and at the end of that, does he need further testing? Yes. We're going to do a PCR at the end, just a qualitative one, and we're going to do his liver enzymes. Now, someone sort of asked in the chat, do I do 4 or do I do 12? I personally do 12. I like 12 weeks after, because by that time, if your liver is going to settle down, it really definitely will have settled down from HCV. So you've really got a good chance of looking at the liver tests and getting meaningful data there. But if someone really wants to be through with it and you're not clear on whether they're going to turn up again, 4 weeks is an acceptable time point to measure your qual. Does he need ongoing specialist care? Not at all. He's done. So you don't need to have him referred back to us at all. If he's got cirrhosis, it's a different kettle of fish. And even somebody with advanced fibrosis, we're really not sure just how to treat these patients. So if you want to run them by a specialist at the conclusion of the therapy, we'd be happy to sort of have a think about that and come up with some strategies for management there. Mark, yeah, he's cured. Okay. Egan, I'm not sure who does this, but I can do it. Mark is occasionally injecting, and he's got an ongoing reinfection risk. And what do you do there? Well, essentially, you just want to really give clear advice about how injecting exposes individuals to infections and harms and provide it on a practical level, including someone having access to a needle and syringe program. You don't have to keep going with antiviral testing. I would ordinarily do liver enzymes. You don't do antibody because it will always be positive. And the RNA for somebody who's injecting, I think, is a worthwhile test, even though not a lot of them do. Okay.
Fabulous. Thanks so much, Scott. That's tops. I think we've got one question I couldn't really answer in a diplomatic way from the if a patient who is already on a DAA goes into prison, would Justice Health continue the treatment? Is it available in all prisons? Is the question.
The answer is no, and that's an indictment of justice. Justice, in my my course opinion, is indifferent to the health of the individuals who arrive in the service, and the fact that they've got a bottle of tablets with a really clear indication and a good management strategy ready to go, it won't be adhered to, and you probably will lose that therapy, and that's not the end of the world. Thankfully, I've got some really, really dear colleagues who work tirelessly to try to provide high quality care to patients in prisons, and I have received patients from prisons who are on therapy and received cirrhotic patients post-therapy for ongoing management. And that can work quite well, but in my, I'm sorry to be pessimistic, but it's unlikely. What do you think, Nada?
I think it's getting better. I think there's a real push to try and, but I think it's quite difficult to actually continue medicines that were in community in prison, but also the same continue medicines that started in prison in the community. So yeah, I think that's about it. I think we've got 2 plugs left. I think one is a plug for your awesome project.
Echo.
Yeah.
So telementoring is kind of an instant hand-holding experience. You're able to put the data into the remote access page, send it to us, and then once every, I think we're doing it every 2 months at the moment. We talk about viral hepatitis, and in particular, we'll talk about um, um, cases like this with general practitioners and try to make sure that your support needs are met. And it's really quite interesting. I think most of the people who turn up don't get tired of me talking for 45 minutes, even though I'm surprised. But anyway, and I've got a great panel. I've got a social worker and I've got drug and alcohol people and sexual health people who are part of the panel. And the diversity of information that's generated out of Project Echo is fabulous. Got another hepatologist who helps with it as well. But if any of you wanted to get involved, look, please do. We really do appreciate getting cases from the community. And you don't have to, I know you're all busy workers, you've got practices to attend to. So we're not trying to make this onerous in any way, but we'll try to meet your support needs through Project Echo.
Awesome. And just a plug for the project that I'm involved with called Motivate C. It's a project to look at whether or not cash will assist anyone that's a little bit reluctant living with chronic hepatitis in the community engage in treatment. So there's some fantastic, I guess, potential cash rewards on offer. Googling Motivate C will get you to the project page and you might be able to navigate through that with your patient. But also we have remote online GPs that will be able to prescribe treatment for your patients as well. So it's been really great in regional and rural communities. That's it. Thanks so much. All right. Thanks, Serena.
Thank you. I would like to extend my thanks to Scott and Nada for presenting and also everyone who joined us online. We do hope you enjoy the session and that you also enjoy the rest of your evening.